5. Hello, I'm Alan Mendeloff, a member of the Wisconsin HFMA chapter. Welcome to our video learning series for achieving the Certified Healthcare Financial Professional designation. As healthcare professionals, we work in a reform environment that requires entities to fundamentally rethink their business model. The new CHFP exam reflects this changing reality. A reform environment presents every healthcare organization with the same fundamental set of challenges: to identify new opportunities, devise creative responses, launch new solutions to achieve positive impact, and to sustain those gains. The emphasis of HFMA's certification program is to develop the skills needed to participate in shaping this business environment. A critical reality is that organizations today must be learning organizations that continuously measure and understand the business environment, translate goals into actions, execute effectively, and evaluate results. Our industry needs people who can lead change in a fluid world. So the purpose of the CHFP program has shifted toward continuous learning, not just demonstrating experience and expertise. A critical business issue is the recruitment, development, and retention of competent talent. The new CHFP program is intended both for individuals to use in advancing their careers and for organizations to use as a component of a comprehensive talent development program. The first of 2 modules is called The Business of Healthcare. This module's focus is on understanding the business environment from a finance perspective. Importantly, this module includes the business realities for payers and physicians, as well as hospital providers. A fundamental business assumption in building the module content is that CHFPs will work in a collaborative, multidisciplinary workplace, resulting from the transformation from providing care to managing health. The second module is called Operational Excellence, focusing on specific payer, physician, and provider business concerns. The second module utilizes case studies to present candidates the opportunity to see real-world business situations and to test their ability to apply the knowledge gained in the first module. This module encourages multidisciplinary thinking and appreciation for other professionals' business concerns. With these goals in mind, the chapters of Wisconsin, Connecticut, Arizona, and Vermont, New Hampshire have collaborated to bring you the following learning module. Today's speaker is Dr. Jeff Helton, Assistant Professor of Healthcare Management at Metropolitan State University in Denver, Colorado. He brings over 25 years of diverse experience in healthcare financial management to his academic work at MSU. He is a certified management accountant, a certified fraud examiner, and has held the position of Chief Financial Officer at several hospitals, health systems, and health plans. He specializes in fraud accounting, reimbursement analysis, internal audits, operations evaluation, and large-scale data analyses. Dr. Helton received his master's in healthcare administration at the University of Alabama, Birmingham, and his PhD in healthcare management from the University of Texas School of Public Health. He has published and lectured on a wide range of risk management and business topics, including the Affordable Care Act. Additionally, he has hands-on experience in managing operational departments within Medicare and Medicaid health plans, with research interests on the impact of technology on healthcare operational efficiency. He is a fellow in the HFMA, and his topic today is Looking to the Future. Dr. Helton.
Well, thank you for that introduction. I really am excited to have a chance to be a part of sharing some ideas about the future in healthcare and how we in the finance profession can really make a positive difference. What I hope that you're going to be able to do after our discussion today is describe some of the new models in healthcare. Next to national defense, healthcare makes up 20% of the gross domestic product in the United States. And a lot of that is driven by the way that we pay for healthcare services. And so hopefully you see after the completion of this course how those past reimbursement models might have influenced how big healthcare has become in our economy, and how the healthcare system is evolving to try and not necessarily stop that growth, but make sure that that spending is for a good outcome, for good ends. We'll also talk about some of the general characteristics of healthcare and the impact of healthcare reform. Business intelligence will kind of help us understand those impacts. We'll have to use some of our understanding of the general healthcare system to frame a question that we can answer with our business intelligence tools, and our understanding of healthcare in general to also understand what's the differential impact if we make a change in reimbursement. What's that going to do to patient care? What's that going to do to our costs of healthcare? What's that going to do to the costs paid by our partners in the healthcare system? Finance professionals are going to have a big role, and I emphasize big role, in the future world in healthcare. We're going to have to become partners with physicians, with other healthcare professionals, nurses in particular, as well as working with payers. If you work in a provider organization, you're probably used to seeing a little bit more of a competitive or us versus them sort of relationship. And those things are going to have to change, because we're now starting to have to work together to find out how we can best meet the needs of the patient and maintain a sustainable rate of growth in the healthcare sector of our economy. And that's going to be a big challenge for us, because previously we've been able to just grow the healthcare sector without much constraint. But as we start to kind of see that maybe we're not having all the money to spend in healthcare we used to, we're going to have to learn how to work smart instead of work hard. In addition, there's a new concept in healthcare, and that's called population health. Previously, we've kind of worked toward the end of, really just treating injury and illness. Whenever the patient is sick or injured, the healthcare system steps in to repair or mediate that problem. That's great if you're a healthcare provider, because every time someone gets sick, that's additional revenue. However, that growth, that impetus to increase revenues through identifying new illnesses, new opportunities for treatment, has come up against that economic constraint I just mentioned, where healthcare is getting so big it may be getting hard to afford in some parts of the economy. Population health, as you'll see later in this presentation, is a way to possibly address that, and it creates a bit of a different way of thinking for those of us in the healthcare field. Finance will be a big part of helping to inform that new paradigm, if you will, in managing healthcare delivery. And then finally, apply a lot of the lessons learned not only in this course, but hopefully you'll connect the dots with some of the prior courses that you've had in your preparation for the CHFP exam, and apply them in your work in the healthcare industry. We'll talk a little bit at the end of this presentation about the what's in it for you, or how's it going to impact you as a worker in healthcare finance. So with that backdrop, let's get to work. You need to know a lot of things in order to pass not only Module 1 or Part 1 of the CHFP exam, but especially in Part 2 when you go into the applied section of the examination. We're not going to be able to teach you everything because it's a case-based examination. And this learning program hopefully will help you kind of connect the dots between the actual reading and going through exercises in the CHFP learning module from HFMA. But what we're going to talk about in this presentation is some of the key stuff you're going to need to do to know, and also maybe how to expand the thoughts that you'll see in the training program just a little bit, and hopefully help you apply it a little bit better when you get into part 2 of the CHFP exam process. As a result, this presentation is just going to be an overview of important concepts, maybe a little bit of additional depth that you don't see in the readings, just to kind of help you, again, connect the dots, hopefully with some of the other modules. The real in-depth information that you're going to need to pass Part 1 and Part 2 of the CHFP exam process comes from the online course. Okay, so let's talk about the evolving models of reimbursement. You'll hear a lot, especially in the media, about healthcare being very inefficient. And we might stop and think, well, gosh, we work all the time on trying to become more efficient, to look for lower cost ways to acquire supplies, more efficient staffing models, more efficient means of organizing patient throughput, let's say through our ambulatory services or through our emergency room. That's not what we're talking about here. But instead, we're talking about inefficiency overall, and how our reimbursement system really creates an incentive for providers to provide more services, even if those services may not necessarily be the best service for the patient at the time. So what we look at is trying to balance, if you will, the incentive to provide enough services to take care of the patient against the need to maintain revenues and maintain the fiscal viability of our organization. The way that reimbursement has been accomplished in the healthcare system up until recent times has been what we call a fee-for-service model. I liken it to a piece rate, if you will. If you think about a worker in a factory who's paid per unit of output, every time they put a bolt on a screw, or a nut on a bolt, or if they weld a door, or something like that, they get paid for each one of those new units of output. Healthcare has been very similar to that for many, many years. And with that piece rate sort of payment comes the incentive to provide more pieces of service. And that has driven a lot of the growth in healthcare costs and created some of the issues that I mentioned earlier in this presentation. And so we have a strong incentive to provide more services as healthcare providers. That's great unless you're the healthcare payer or the patient who has to pay for those services. And so again, we kind of run a little bit of cross purposes here. Now, there have been some other models that have come up, especially since the mid-1980s. And I'll highlight in particular the DRG, or Diagnosis Related Group System, or case rate system. Either way, those are payment methods that are based on an occasion of service, whereas fee-for-service, the reimbursement is based on each individual piece of service provided. The room, the medicine, the supplies used to administer medicines, the supplies used for surgery, and so on. Each individual item would be charged under a specific sort of charge-based fee-for-service reimbursement mechanism, and you'll see more about more of the details of that in course 6. However, the DRG, or per case rate, rolls all of those individual units of service together into one payment. And that one payment per outcome was supposed to be a way to help stem the tide of healthcare cost growth that came from this fee-for-service mechanism. One small problem comes up with that, in that the provider still has a very strong incentive to control costs for each individual occasion of service, but they don't have an incentive to try and find opportunities to have more occasions of service. And so you've probably seen this in your work. I know I've seen it many times in my work in the field, where we'll be very focused on taking care of a specific sort of issue for the patient, receive the payment for that specific service, and then have the patient come back after a specific period of time, usually dictated by Medicare regulation, to take care of other issues. Again, for an additional specific payment for those additional issues. Either way, it creates the incentive to provide more services. Same thing happens with something we call a per diem rate or a per day rate. In this case, the healthcare provider is reimbursed, and we're talking more about hospitals or skilled nursing facilities with a per diem. They're paid per day of service. So what's the incentive if you're a healthcare provider? Provide more days of service. So again, even though we're incentivized to keep our costs low per day, we have an incentive to provide more days of service. So again, it kind of goes back into that idea of a sort of inherent inefficiency, because the more we provide, the more we get paid. In the early 1990s and really through the mid-1990s, there was a growth in a reimbursement mechanism called capitation. And it was meant to be used as sort of a step toward addressing some of the incentives for inefficiency that I just described. Now, a quick refresher: capitation is a payment per person or per head, if you want to take the Latin derivation of capitation. It's a payment per head per month. It's a fixed amount to cover all services defined under a contract for an individual for a specified period of time. It's a very strong incentive for the provider to reduce the costs of providing care to a patient and be very focused on what it is that the patient needs. However, you'll notice I highlight here, that's also an imperfect act or method, and it is because it creates kind of a polar opposite incentive to what I just described. Under fee-for-service, we have a incentive to provide more and more and more and more services. Under capitation, it's the exact opposite. We have a very strong incentive to limit the number of services. Now, we hope that as healthcare providers, we do the right thing by the patient and provide the services that the patient needs. However, some would argue that capitation took it just a bit too far. And we'll talk more about that when we get into comparing capitation with some of the new delivery systems that we see evolving in the industry. So as I mentioned, capitation has limitations. It really has a very strong incentive to limit care, and we have to be very careful about that. The other thing is capitation contracts tend to be very specific to a given type of service. And so there's not a lot of incentive for a provider. Let's say we have a primary care provider who's capitated for all primary care services for a group of patients. If that primary care provider can provide those services within that capitation contract, they're expected to do so. However, there's not much of an incentive for the provider that receives a capitation contract to work collaboratively with other providers to kind of connect the dots with patient care, to make sure that the prescription decisions made in the primary care setting work with the prescription decisions that might be made by a referral specialist, as an example. And so capitation really creates a bit of a, if you will, sort of a siloed environment, where within each capitation contract for each type of service, everybody works within their silo. And not much of an incentive to work across silos, really optimize the care provided to a patient and really create the best quality outcome. And so the evolution that we're going through now is looking at how can we link reimbursement to quality outcomes. rather than paying providers just for the literal output of healthcare services, let's try and connect all of the different services within the healthcare continuum, make sure that the patient's doing the best, getting the best outcomes that they can. And this really sort of hits the ground with the Affordable Care Act. There's a lot stronger incentive for providers to coordinate care and to provide only the care that's needed. So we start to work toward that end that I mentioned a moment ago, where we're trying to kind of move from a volume of services to getting good value for what's spent. Remember, I said a few moments ago in my opening comments that we're not necessarily looking to just stem the tide of payments for healthcare, but instead to make sure that we're getting good value for what is being spent. And we in the healthcare field are going to kind of have to show some value and show the value add for the services that we're going to be being paid for. Now, one of the biggest areas of confusion I see when I talk to folks about these evolving models is the difference between the medical home and the accountable care organization. Some people would tend to use them kind of interchangeably, and I would say, not quite. They're in fact two different but related types of healthcare delivery system. The patient-centered medical home, or the dark blue circle that you see in the middle of the slide here, has really been around actually for decades. It started in the pediatric specialty as a way to kind of get everybody on board with taking care of pediatric patients and organizing care. There even was to the point of setting up coordinated care teams within pediatric practices. And then it moved out to family practice and general practice, and expanded then even to most all of the primary care specialties that we know about, many of them referenced in Course 1 of the CHFP preparation materials. The medical home tends to focus primarily on the primary care specialties and then those caregivers that work with them, such as nurse practitioners, physician assistants, pharmacists, maybe even dietitians or nutritionists or health educators. Some of the more advanced medical home models actually will even include a social work element. Help patients who may have challenges with transportation, access to caregivers to help provide respite for family members, things like that. And so we're really looking at trying to, within the patient-centered medical home, organize those primary care services to make sure that the patient's getting what they need when they need it. And there's a coordination element involved, because certainly we want to make sure that the nutritionists know about findings from social workers or from health educators. Pharmacists need to know the decisions made by nutritionists because there may be a food-drug interaction that has to be dealt with. Nurse practitioners, physician assistants, physicians certainly need to kind of see that bigger picture. All of that is organized through the patient-centered medical home, and especially through the use of health information technology. With the passage of the Patient Protection and Affordable Care Act in 2010, the Affordable Care Act, or Obamacare, took that patient-centered medical home notion and kind of carried it out another step, if you will, expanded it a little bit into a bigger model, and I'll talk about that more in just a moment. But the one thing that it does kind of push toward, the patient-centered medical home was still more of a fee-for-service type of underlying reimbursement model. It was just organized to try and make sure that the patient was being well taken care of, everything was efficient, well organized, but it was still a fee-for-service model. Under the accountable care organization that came out of Obamacare or the Affordable Care Act, we put that patient-centered medical home into more of a different reimbursement model, where the patient-centered medical home works with other providers outside of those primary care sort of focused providers, all of them sharing reimbursements together. So they have to work together and actually share revenues. Let's talk more about that. The Affordable Care Organization, or the Accountable Care Organization, is a network of healthcare providers, and it's more than just primary care providers. So that's why I'm going to flip back for a moment. It's bigger than just that patient-centered medical home. But instead, now we're talking about integrating hospitals, home health agencies, maybe ambulatory care centers, diagnostic centers, outpatient pharmacies, and so on. Having multiple providers that are not necessarily just primary care specialists, also surgical specialists, all together in an organized network. Now, the key difference between what we saw in the past fee-for-service world and also what we saw in the past iterations of the patient-centered medical home is that all providers in the accountable care organization share financial and clinical responsibilities. Now, when we're talking about financial responsibilities, we're talking about a different sort of bent on capitation. The accountable care organization will still be able to be paid fee for service, and I'll talk more about that reimbursement model in a minute, but at the end of the day, the accountable care organization will have some responsibility for maintaining total costs for a defined group of patients at some specified target level. In addition, the accountable care organization also is going to have some responsibility for clinical outcomes. They're not going to be paid just for providing more and more and more services, but instead also have to prove that the volume of services provided lent a quality outcome or a good outcome for the patient. And there are a variety of different ways to measure those sort of clinical outcomes and define those clinical responsibilities for an ACO. The ACO serves a defined group of patients, very much like the capitation model I described a little earlier. However, there's going to be one difference, and that is the definition of specification of the group of patients will be a little bit fluid. I'm going to come back to that in just a moment. Now, a key feature that does harken back to this diagram is the fact that the accountable care organization does include medical home. And the primary care physicians that may make up that medical home are really the lead in their lead role. The primary care provider tends to be somewhat of the conductor, if you will, of that healthcare orchestra that provides a variety of different services to take care of the needs of the patient. So really, the ACO is the next big step in the evolution of our healthcare delivery system. There are some challenges, to be sure. One I just mentioned a moment ago. The definition of a defined population is going to be a little bit fluid under the ACO. And we're going to have some challenges as healthcare providers working in an ACO to know just who it is that we're responsible for. Because patients, unlike with the capitation model, patients that are in an ACO can still seek care from providers who are outside of the ACO. The ACO payment model instead defines who your organization, your ACO, is responsible for based on, does your organization provide the majority of services to that patient? It's a concept we call attribution. And we in the finance profession are going to have some big challenges from two perspectives. One, helping our clinical partners define that attribution logic, understanding what patients are going to be part of our ACO, and then helping to maintain sort of an oversight of the costs of patients that are going to be attributed to our ACO, and tracking the resource utilization for those patients. So a tough thing that we're going to have to deal with, and finance is going to really be a key part of it, is understanding who's assigned to the ACO, who's going to be attributed to our care, because that helps determine how we manage costs, and it could have a significant impact on the amount that is spent for that patient that we're held accountable for as providers in an ACO. But it also could impact the quality outcomes, because if a provider outside of the ACO is rendering care, that may impact our quality outcomes. We really have a big challenge here in terms of knowing who we're responsible for. Now, we can influence that with patient loyalty. If we can keep patients seeking care within our ACO, then we have a much better idea on who we're responsible for. So we're going to have to work on maintaining a degree of patient loyalty. I hate to say it in such a colloquial way, but keep them coming back, because it really is important to us to keep a close eye on that patient and help us be able to manage the costs. Once a patient goes outside of the ACO, it's going to be a lot tougher for us as an ACO to manage those costs. Much tougher still in terms of trying to manage the quality of care provided to a patient in an ACO. And so we really want to try and keep those patients close to us, and be able to keep the bundled payments that often are a part of an ACO within the family. When a patient has to leave the ACO for services, the additional cost can be an offset against our bundled payments. We could actually, as providers within an ACO, lose money if patients leave the ACO. So we really want to work hard to keep patients seeking care within our ACO. Now, that raises a little bit of a challenge for providers in an ACO when we use bundled payments. Essentially, it's a fee-for-service payment. We're still going to get paid a specified amount for a specific service or a specific occasion of service. You'll see in the Module 6 training materials, we use the example of a surgery. A bundled payment for a surgery would encompass not only the surgeon, but the facility where the surgery is provided. The surgeon's services to diagnose the need for surgery, the provision of surgery, and then the follow-up care afterwards. If that surgery happens to be an orthopedic surgery, or perhaps there's outpatient physical therapy involved afterwards, then the bundled payment would include that outpatient physical therapy afterwards. It really becomes a collaborative care model. And so you have all of the providers working in this bundled payment having to work together because they're all splitting the same pie. And so you want to make sure that there's a collaboration, everybody knows what's going on, so that you can work efficiently within the limitations of that bundled payment amount. Now, there's also a degree of funding autonomy involved. It gives the providers that are working under this sort of arrangement some freedom to kind of split the pie as they think it's most efficient or most advantageous for all parties. In many cases, in the past, I've seen situations where it can be a little bit of a tug of war between, let's say, hospitals and their medical staff working in a shared payment arrangement. Usually there were like risk capitation types of models where there was very much of an us versus them type of relationship. The bundled payment sort of changes that model to a great degree and allows organizations instead to say, what's a fair division of the payment? And with even more multiple providers involved, there really is a greater pull for collaboration amongst all parties within the bundled payment. Now, there can be rewards for sure. To the extent that you can deliver care more efficiently than you did in the past, you make more money under a bundled payment. There are also risks. The extent that you have a patient that has untoward complications, other things going on that raises their costs, certainly there's a risk that a provider could lose money under a bundled payment. So you really have to work on being collaborative amongst your care partners to make sure you can minimize those risks. You can't make them go away. They're very much with any other sort of prospective or fixed payment. There are going to be some winners, some patients that the organization can make money on. Some we're going to lose money on. We just hope that we win more than we lose. We make more than we lose on, we should say. And within that, we have to be very careful about who we partner with. In the past, I know as a former health system finance officer, we used to look at our partnerships around who could bring volume to the organization, who could bring more patient admissions or patient discharges, more surgeries, or volume in general. That may be good under a fee-for-service model, but now when we start talking about bundled payments and we have to be more efficient and we have to deliver high quality, we may have to reconsider who we partner with. Does that high volume provider really provide good quality of care, or do they just turn out more and more and more and more care? So we'll have to be very reasoned, very thoughtful about who we partner with, because we're sharing the risk of the costs of care with our partners. We want to make sure somebody's going to be able to handle their share of our money reasonably so that they're not taking money out of our pockets as well. It's a very fine line that we're going to walk. I'm not sure we as a field yet know exactly how to walk that line. You're going to be part of that evolution. All right, so let's talk about why bother. What's the point? So with an ACO, with a medical home, with these bundled payments, all of these things together are trying to get providers to work together to generate positive patient outcomes. In the past, I know throughout many of the years of my career, when working under the Medicare DRG or prospective payment system, we were kind of working at cross purposes as a hospital with our medical staff, because the hospital was paid that DRG payment. It was a fixed amount for the services for the patient discharge. We had physicians who were paid on more of a fee-for-service basis, where they were paid more for all the services they could provide. So we were kind of, again, in a little bit of a tug of war, where a physician had a pretty strong incentive to provide more services while the patient's in the hospital. The hospital, on the other hand, had a pretty strong incentive to kind of push back against that decision and say to the medical staff, do we really need to do that now within the admission, or can we do this as an outpatient at a later time? The goal of the medical home, the ACO, the bundled payment, is to take away that sort of tug of war, if you will. Get providers kind of pulling all in the same direction, really aimed at generating positive patient outcomes and doing what's best for the patient within the constraints of that bundled payment. So we're really talking about aligning incentives. We're all trying to deliver care efficiently to the patient, rather than, as I just mentioned, we have one party trying to limit costs, another party having a very strong economic incentive to provide more services. Instead, we're all now working within one bundle of payment, and we're all working together. And so it really does decrease the incentive for providers to kind of strive to provide more services. Volume, 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 as kind of used to be the mantra. And so we move away from that because instead we have an incentive to focus on quality. And because ACO payment mechanisms have a quality element to them, there are actually bonuses that you'll see, again, as part of the training materials in Module 6. You'll see part of the payment for an ACO includes quality. Money can either be taken away from the ACO or given to the ACO based on performance on quality measures. Now, those quality measures will vary depending on the structure of the ACO, the payer relationship that ACO has with other insurers. We in the finance profession are really going to have to rely on our clinical partners to help kind of identify what those quality issues are. They're going to have to help us monitor performance on those quality measures so that we can properly account for revenues and for perhaps for possible liabilities for penalties if we don't meet quality goals as an ACO. All that to say, we're working on a focus on quality of outcomes because we have to provide some evidence that we gave a good service. Going back to my earlier comments about saying we don't want to stop the flow of funds into healthcare, we just want to prove that the funds coming into healthcare are a good spend. Now, we in the finance profession have a bit of a challenge. That is, what are we going to do to maintain revenues? Because now we're talking about fixing all of our payments within a sort of constrained box, if you will, that we call the bundled payment. And that's great, but we still have an expectation of growing revenues, of making sure that we grow revenues sufficiently to cover growth in costs. Obviously, none of our vendors are going to hold the lines on their costs for supplies. Our employees are not going to without a pay increase. So we really have a challenge to maintain revenues. And so we're going to have to be very, very judicious about how we use those resources to make sure we can maintain margins and, where possible, reasonably grow margins. We get there through kind of understanding our business. And we do that through a couple of different ways. It's called being smart, really. We are going to have to rely very heavily on data and really understand the costs and the utilization of services by patients in our new delivery systems. Because we have a penalty for adverse outcomes, there are now patient services that won't be paid for if it's a sort of a never event. We really have to be very careful that we monitor resources. Business analytics and business intelligence help us kind of understand the data that we have sitting right in front of us to understand those very risks I just described. Now, many people will use business analytics and business intelligence, again, sort of interchangeably. And again, I'll wag my finger and say, that's not quite right. They are, in fact, two distinct, different processes. Now, business analytics is more the sort of simple version of it. Those are the software tools that we use to kind of capture, analyze, sort, get some rudimentary understanding of what's in the data. Sort of converting data into basic information, if you will. Business intelligence, on the other hand, is taking that information and understanding it in the big picture. Understanding just what does this mean to us. And so business analytics really converts data and information. Business intelligence takes that information, interprets it, and helps us as management make good decisions that can help hopefully address some of the risks, some of the objectives that I've mentioned already. It's a very fine line very much like people use data and information interchangeably. They are not interchangeable, as hopefully I've just highlighted. So let's make sure we understand as we go back out into the field, analytics is really just generating that basic information. Intelligence is understanding it and using it to make good management decisions. So I'm going to jump ahead to business intelligence and say, so how do we do that? Well, I'm going to kind of make the assumption for the moment here that we have business analytics abilities already through the applications we have. Certainly many of the good electronic health record applications have a business analysis type of function available. Most of us are able to run reports from our patient accounting, our general ledger systems, to help get good information from the financial side. We work with our clinical partners to bring in analytical data from the clinical side. We wrap all of that together in an analytical process to generate good information. We're now going to take it a step further and say, how do we implement a good business intelligence type of function? Well, it starts with data strategy. What I mean by data strategy is, what data are we going to use to make good business decisions? Many people have said in the past that healthcare is a very data-rich environment, and I believe that statement is very true. We have wealth of data, especially now that we have an electronic health record which captures clinical data at a level of detail that really we could not get back in the old pen and paper chart days, because the electronic health record prompts the caregiver to provide more information. Hey, doctor, hey, nurse, did you remember to record this particular piece of information? Also, we have automated clinical data recording from many of our clinical care devices, all of which feed in the electronic health record. So we really do have a wealth of data. Not all of it do we need in order to make a good business decision on patient care. So we have to have a data strategy that says, what elements of data do we need to make good business decisions? That's going to vary from provider to provider, organization to organization. So you are going to have to be part of a decision process to say, what data do we need to capture and analyze, convert into information in order for us to be able to monitor our patients, actually run our business. All of that I just described, it can kind of be wrapped up in this term we call metrics or ratios. What sorts of things are we going to monitor? We're going to monitor length of stay, admissions per 1,000, maybe ER visits per 1,000. Are we going to monitor primary care outcomes? That's a hard decision, and really one that a lot of us in the finance field, I argue, should not make in a vacuum. We have to work with our business partners. We have to work with our clinical partners. And probably the best place to get guidance for what metrics that we're going to monitor comes from our business plan, from our strategic plans. As we try and move our organization toward meeting its business or strategic objectives, that's set out in our business plan. So let's use the objectives set out there to kind of help illustrate, what do we need to monitor? What metrics do we need to monitor to get us toward our goals? You don't need to monitor every metric, every ratio. Now also, we need to have good, timely access to data. A really good report that provides volumes of data that we can then kind of sort, collate, come up with some good information. It's really helpful if we have it when we can act upon it and kind of change course or address what's happening in the organization to get us back on course toward our business or strategic objectives. Having a great report that comes in a month after the decision needed to be made really isn't very helpful, is it? And so we want to make sure, as part of our business intelligence function, of our business intelligence process, that we're providing data to decision makers. We're providing good reporting to our senior executives on a timely basis so that they can make a decision that can kind of help us keep on track. Data integrity is a huge issue, and even more so now because we're placing a great deal of reliance on automated tools to gather data. And so we have to be very careful about data going into our business intelligence sort of, if you will, bucket. And data integrity actually is a long-standing concept. The NASA, the space agency, back in the 1960s came up with a term they called GIGO, G-I-G-O, which stood for garbage in, garbage out. If you put garbage into your computer system, you would get garbage out in terms of information you needed to make a decision. I would argue that old concept is still very relevant today. And I'll use an example that comes close to heart for me, working with organizations that are trying to develop a health information exchange and share data back and forth. Again, kind of going toward the concepts I mentioned a few minutes ago in terms of collaboration between organizations. Data integrity problems could come up if, let's say we have a patient whose name is Jonathan Smith. And Jonathan Smith's information is recorded at one provider as Jonathan Smith. At another provider, it's John Smith. And so even though it's a fairly simple sort of dichotomy that you see there, when we start trying to do data analysis, it can become a big problem because it could literally identify in the data two different people. That's a very simple sort of example, but just to give you an idea that we have to be careful to make sure that we're maintaining a good quality of our data sets so that we don't have to rationalize, oh, we have a Jonathan and a John, oh, but they're the same person. And so it's going to be very important to us to make sure that we have strategies in place, procedures in place, protect the integrity of our data, make sure that we're collecting the most accurate data we can, because under a good business intelligence function, that data is going to be used to illustrate and illuminate the decisions that our executives are going to be making. And a lot of it is going to, again, feed back to what I've been harping on a lot through this presentation, is collaboration. And it would be good if multiple partners working in, let's say, a bundled payment relationship are collaborating together. Or they're measuring the same metrics and that they're interpreting results the same way. Having good data integrity strategies where everybody's recording data the same way, measuring the same metrics, interpreting the results of the same metrics the same way, really has everybody, as I mentioned earlier, kind of rowing in the same direction or aligning to drive value. The HFMA Value Project defines value as quality in relation to the total payment for care. And that's really a challenge for us in the healthcare field, to make sure that we're doing this, that we can demonstrate good quality for the price paid for services. And in order to do that, finance might be called upon to help kind of demonstrate what is that value proposition, if you will. Well, I know I'm an accountant, if you are accountants as well. We may be a little bit challenged when it comes to that quality element, because there's a clinical element that may be outside of our training. And so we really are going to have to rely on our clinical partners to work together. This has been a little bit of a reform element for me personally, as a healthcare finance officer going back into the days of cost-based reimbursement. And it's been hard for physicians to work collaboratively with finance people to work collaboratively with physicians or our clinical partners. In the past, and you may have seen this in some of your travels through the industry, we in finance are very attentive to cost and to make sure that we're keeping costs as low as we can, because we're trying to stay within that fixed budget, whatever that DRG payment or that case rate is or that per diem. Firstly, we have our physician partners, our nurse partners, trying to take care of the patients. And they're trained to really look for the patient's interests first. So again, we kind of are working at this sort of cross purposes. And we need to kind of take that away and start to work more collaboratively, because we're going to have to rely on each other's training and expertise, really our understandings of a different sort of perspective on the patients and patients' needs in order to do a good job under this new model of accountable care, bundled payments. And so we really have to have open communication between finance and clinicians. I've been part of several roundtables working with physicians now, and in some cases we've had to have a little bit of a clearing of the air sort of thing to kind of understand, well, this was my perspective worrying about cost. This was my perspective worrying about the patient's outcomes. Trying to bring that together to say, okay, doctor, I hear you in terms of the need for the patient. Could we try perhaps this rather than that to meet the patient's needs, because this perhaps lower cost alternative may be a better outcome? Physicians can then weigh in on that, and our nurse partners really can be very significant in that. I know in the past we in finance again have kind of a little bit of cross purposes with our nurse partners in terms of trying to constrain resources used in the patient care areas versus our nurse partners trying to get what they need to and what they believe to take care of a patient. So really are going to have to kind of change that and work together because we're all pulling in the same direction to kind of get toward that higher level of outcome, if you will, good outcomes for the patient at a reasonable cost. That value proposition that we talk about. One of the tough things that we deal with in working with defined populations of patients in particular is chronic health and chronic health conditions. So we're going to have a tough time going forward getting together and understanding how can we provide care to the patient that's most efficient, what the patient needs at a low cost. Part of the way we're going to have to do that, as you can see in the diagram here, is kind of pull together a lot of disparate pieces that may not have been part of our conversation before, particularly in finance, where we're going to start integrating financial data with clinical data, or clinical integration, if you look at sort of the 2 o'clock position in this diagram here with clinical integration. We're going to integrate our data sources and help each other sort of analyze what's going on. What are the costs and the number of visits? Are the number of visits for the right type of service? So moves toward population analytics, or on the 3 o'clock position on this circle here. And understanding who's using what resources. Do we have perhaps a group of patients in our population that are not using resources properly? They continue to go to the emergency room when perhaps they should go to an urgent care or actually go see their physician. And integrate that with care management, where care managers kind of look at what are the needs of the patients, what are patients seeing the emergency room for, why are they going to their physician, and coordinate with other providers, perhaps lower cost providers who can provide the same level of care but at a lower cost. So at the bottom of the diagram here, we're coordinating care. And we're reporting and measuring outcomes as we start to see, can we move patients toward a more efficient or effective delivery setting for their healthcare needs? Are we lowering costs? Are we improving outcomes? A lot of that's going to involve engaging the patient. Now we're at the kind of the 9 o'clock position on this diagram here. Patients oftentimes want to do the right thing, they just don't know what it is. So we can provide them information, education, maybe even a few incentives to do the right thing within our population health management strategy. That may even involve telehealth, integrating their cell phone, their smartphone, with our network of information to help them perhaps monitor their diabetic condition. Maybe have reminders go out to their, a text message reminder to their cell phone. Have they checked their blood sugar today? As an asthmatic, taken their inhaler medications, and so on. All of that kind of wrapping up in looking at claims and beneficiaries. If we're monitoring claims, we know who's getting services from what provider. We can help kind of know who are the beneficiaries that we're going to be responsible for under an accountable care organization type of model. So we're managing claims and beneficiaries. Now there are some challenges in population health management that we in the finance field can be instrumental in supporting. That's helping determine patient care needs. And I'm not saying that we in the finance field should help make clinical decisions. No, but instead, we can inform those decisions. We can provide data to our clinical partners to say, we see a pattern in costs. It seems to be focused in a particular area. Helping our clinical care partners make some good decisions about what the patient needs, and then make a decision, okay, can we provide this service within our network, or do we need to buy it from outside the network? The classical business make or buy decision. And then measure performance. Obviously, we have to know what metrics define performance, but hopefully we've gone through that step as I've illustrated earlier in this presentation, and we know what metrics define performance. We in finance help to illustrate what our performance is through our analysis of data and providing business intelligence to our executive leadership. Certainly understanding costs and where costs are going can help us determine what are the incentives for participants. How can we incentivize the behaviors we need to have in order to be successful with a population health management strategy? And obviously, we have to manage what we measure. If we're going to have metrics that we're going to use to define performance, well, if we're going to calculate those metrics, if we're going to publish them to our executive team, we want to manage those metrics and kind of use them. It's very much like having a suggestion box where you put suggestions in, but no one ever looks at them. Very much the same sort of thing. We want to manage what we're measuring. And if we're managing certain things within our population health strategy, we want to make sure we have metrics that measure those strategies, that measure toward those outcomes. So it really does have a very sort of structured approach. So the implications, what's in it for you as we wrap up our presentation here? Our business model is changing rapidly, and it's changing in a very difficult way. We're moving from being evaluated on a volume of services to the value for services. We're going to have to try and maintain revenues, but also maintain revenues by proving that this is the best spend for our customer. That's going to require us in the finance field to really take on a new set of skills. We're going to have to work in collaborative teams that 10 years ago, maybe even 5 years ago, were unheard of for those of us in the finance field. Work closely with clinical partners and understand clinical data. And have a sort of multidisciplinary approach where we're going to get input from other disciplines that we work with. And instead of minimizing cost, we're going to have to optimize cost. A lot of that is going to come from kind of seeing the big picture. We're going to have to focus a little less, and I emphasize just a little less, about the numbers alone. What's that lower cost? But instead, look at those numbers in terms of the context of the big picture. What do we need to maintain good quality outcomes, meet those patient needs, while holding costs at the lowest level we can, while still meeting that need? So it sounds a little bit of a paradox, but it really becomes trying to strike a balance between low cost, high quality. And then finally, we're going to have a lot of insight into clinical sciences, to some of the professional practice models that are out there with primary care, with some of our specialist partners. I'm not saying we as finance professionals need to go out and become very skilled in the clinical areas, but instead at least know enough to know when to ask a question. I jokingly say know enough to be dangerous. Be able to look at an analysis and have some general context. Does this make sense? And then know this is when I need to go to my clinical partners and say, help me understand what's going on here. Because the clinical professionals are going to have to help us inform our business decisions, because we have that cost-quality sort of trade-off. It really becomes a focus on taking care of the patient, and if we take care of the patient, we take care of our business. It's a bit of a new model for us. So as we wrap up, hopefully this has been helpful to you. Understand that this really are in that sort of brave new world of healthcare. You're going to be a big part of it. Just take an open-minded view and understand it's no longer about the debits and credits. It's no longer about our income statement and balance sheet. It's about all of that in the context of a bigger picture where we take care of our patients. Thank you for your time. I hope this has been helpful.